Hello everybody. I know some of you don't quite know everybody. So as Vicky said, I'm Nick LePage. I work in the critical care unit. I'm an advanced nurse practitioner there, and I also have sort of headed up and led the clinical site coordinator service, which, as I explained shortly, has sort of developed really over the last couple of years to where we are now, and hopefully a bit about where we're going in the future with it. So just a bit about the history, really. For those of you who've worked in the acute hospital, you'll know that there's always been a number one nurse, as it's been called, who, if you like, is the nurse on site with overall responsibility of sort of the sort of day-to-day management. And there's been various models of how that's happened over the years. You know, if you're going back several years, it was managed by the number one bleep was held by the sort of matrons that were on duty during the day, and then nighttime, weekends, sort of late shifts was generally covered by a band 6 nurse working on a ward, so they'd all sort of take it in turns to cover the number one bleep. At the time, the main responsibility was generally around sort of staffing levels, a little bit about bed management, coordinating transfers, being the first point of contact for an MIP, and really it's more managerial rather than clinical. And there was a little bit of clinical in that they would either attend the cardiac arrest 222 calls, or if you go back even further, their responsibility was to either attend ICU or the emergency department, which were the people generally releasing the 222 or the cardiac arrest team to attend the emergency. So they would sort of backfill the staff leaving that department, because at the time I don't think any of the number ones were ALS providers going back several years. So we've sort of moved on from that a little bit, but however, the big problem really was it was becoming more and more of a clinical role, really. The number ones were being asked to see more and more sort of deteriorating patients on the ward, particularly with the introduction of the news score. And the big issue was the nurses, they were band 6 nurses, so generally experienced nurses, but they were generally in charge of their own department, counted in the numbers, and really they didn't have the time to be able to go and do these sorts of things because they were needed in their own ward. And it sort of all came to fruition, really. I remember we had a particularly busy bank holiday weekend a few years ago where it sort of generally realised that the site coordinator or the number one at that time ideally needed to be supernumerary, particularly at the bank holidays and the night shifts, which were tended to be the busier times of the weekends. So really the clinical site coordinator team was born. Just sort of stepping back a little bit from that, they'd also introduced the night practitioner service, which was slightly before the clinical site coordinators. And I think Moira was probably one of our first night practitioners, weren't you? And you may remember Claire O'Brien and Gary Whitwam, who's still here now in a different role. They were our first night practitioners. So they covered just purely the night shifts, and we weren't covering the weekends at that stage. But we ultimately expanded it to cover the weekends. And then we put a proposal in after that to ideally provide a 24/7 service. Yeah, so we would definitely cover nights, we would definitely cover weekends and bank holidays, and ideally provide daytime cover too, particularly the late shifts, which are often the difficult shifts to cover with the number one, because at the moment quite often they are still being covered by, generally we try and make it band 7s now, but the ward managers covering the late shifts, which is often quite difficult because they're not always working late shifts, and especially now as they're sort of more in a supervisory role, they tend to be doing more early, so covering the late shifts is still a bit of a problem. So really, quick overview of the responsibilities of the site coordinators. So we provide out of hours, nights, weekends and bank holidays, clinical and managerial site leadership. It's where we are at the moment, like I said, working towards hopefully providing a 24/7 service. At night time, we're the first point of call for all acutely deteriorating patients in the hospital. So anybody who's triggering the News 2 score now, has been flagged up as being septic, any sort of clinical deterioration really, we're the first point of call for adult services, not necessarily paediatric and maternity, but certainly within adult services. And we'll go along, review the patients, and if necessary at that point escalate to the consultants. And we also attend any 222 calls that are placed. So we're part of the emergency medical team. We coordinate bed management, so we look at admissions, where best to place patients in the hospital, and that works quite well because generally we have an overview of how busy all the wards are, and whilst one ward may appear to have a lot of empty beds, it might be that they're very clinically acute and it would be more appropriate to place on a different ward that maybe doesn't have so many beds, so which they might not necessarily see. For example, if ED were managing the bed management, they might not have such a clear overview of the acuity of the hospital. Not always very popular job, but coordinating efficient use of staffing resources. So basically that means moving staff from one ward to another if necessary. Fortunately, it doesn't happen too often. Verification of expected death we undertake, and again doesn't happen very often, but sort of initial decision making around MIPs. If there is an MIP called, we'd meet with the ED staff and sort of decide how far to escalate the emergency. So just a bit about leadership. So the clinical site coordinator team sit within the critical care directorate, so they're part of our team, although sort of a subset to the side, if you like. But from a point of view of budgeting and all that sort of thing, they sit under the critical care team. So John Eaton is the overall critical care manager, and I lead the critical care or the clinical site coordinator team. And ultimately, the whole point of the role really is sort of trying to, not necessarily just going out and saying, well, this is what you need to do with this patient. We try and empower staff on the wards to be making those decisions for themselves. So it's about trying to get people to develop learning themselves. So trying to direct them in the right directions. If they can speak to consultants, that's great, because they then gain the confidence in speaking to the consultants using the SBAR tool, that sort of thing as well. So we try and encourage that where possible. A lot of it is around sort of psychological safety really. So again, sometimes contacting the consultants, the ward staff can feel a little bit intimidated by it. They often think, am I doing the right thing? Should I be waking them up at 3 o'clock in the morning? And just having a second pair of eyes to say, yes, that's absolutely right, this patient is sick, you need to be speaking to the doctor, often just gives them that little bit of support and know that they are making the right decisions. And as we say, there's no such thing as a silly question, because we all have areas that we're not so confident in and questions, and so we obviously want to encourage a culture of openness where people feel that they can ask those questions that maybe they feel they should know the answer to, and there's no such thing as a silly question, as we said. Accountability, so team members, so they're all experienced nurses with acute care background really. So where we are at the team at the moment, so we've got Moira, who's just about to start secondment on as the manager of Brockwell, but Moira's got a wealth of acute clinical care experience. We've got Lindsay Mann, who has joined us in just over about a year ago now, who was a trainee advanced nurse practitioner doing a similar sort of job in the UK. We've got the team leaders from critical care, so we've got one whole-time equivalent allocated to the critical care team leaders, so we sort of take it in turn to rotate into that role. So we've just been out for an advert to a secondment to backfill Moira's place where she's doing her role. We've also got, up until recently, we hadn't had a huge amount of other sort of interest in the role, but we've got a few people now who are expressing more and more interest, so we're hoping to get to the point where we're going to get 5 or maybe even the full 6 whole-time equivalents filled, which will enable us to provide a 24/7 service. So we've got some of the team. Ideally, we want to go is to work towards an advanced practitioner service, so we would like the team members to be prescribers have advanced qualifications in history taking, physical assessment and those sorts of things, and particularly useful given that we don't have the junior medical staff on site and the consultants are at home. So that's ultimately where we would like to go in the future, but I think we're quite a little ways off getting to that point where everybody would be qualified. Like I said, there hasn't really been a huge amount of interest in people with those sort of qualifications in the posts. I think a lot of that is these generally are sort of senior people who are settled within their roles elsewhere, so trying to attract people to a new place is quite difficult, and obviously it's quite an upheaval, isn't it, moving to Guernsey. So I think probably the way forward is going to be to try and grow our own advanced practitioners from here, which is where we're sort of heading at the moment, really. So I've sort of said this already, I think, haven't I? Yeah, pretty much said most of that. So negotiation, key part of the role, and I think that's often probably the hardest part of the role as well. The clinical stuff can be quite, obviously not easy, but it's your negotiation skills with other members of the team, which is often the bit people find more challenging. Obviously, advocacy for the patients is a key part of the role, whether that be communicating with the consultants, communicating with relatives or other members of the multidisciplinary team, really. We do a little bit of complaint management, fortunately not too much, but there is a bit of complaint management involved in it. Obviously coordinating the multidisciplinary team. And yeah, you know, if people are having differences of opinions, often we get called to try and mediate those situations. And again, fortunately, it doesn't happen too often, but it does on occasions. And it can be anything. It could be between differences of opinions between patients and staff. It could be differences of opinions between relatives. It could be differences of opinions between the professional team within the hospital. So it is a bit varied. Continuous learning. So like I said, we try and aim to support staff on the wards with their learning. So whether that's just sort of a little bit of bedside teaching as the opportunity arises, but we don't try and come and take over. We do try and facilitate people's learning. Sort of help people with education in the News 2 score, which has just come out. Sepsis screening is a new sepsis tool which has just been developed, which I think is going to be talked about shortly, and the SBAR tools. Do a bit of debriefing as well, so post-emergency situations, it's always good to sort of do a hot debrief immediately post the event, so that's something else that we can facilitate. So developing new skills amongst the team, so Lindsay has just started a non-medical prescribing course. We've got Carlos who's doing his advanced practice course at the moment. So yeah, we are trying to develop in that direction. Clinical supervision as well sometimes, yeah, so whether again it's maybe not formal clinical supervision sessions, but again with staff that have that maybe need to discuss something at the time, if something's happened, we can offer that as well. What we basically audit all the work that we've been doing. So we've just started the audit just over a year ago, really. And within that audit, we sort of set up a database to try and classify the work that we're doing. And just as sort of ballpark figures, really, about a third of the calls that two-thirds of the calls that we attend are for clinical reasons, and about a third of the calls are for for managerial issues, so which might include bed management, staffing, transfers, all those sorts of things we classed under that category. So just a bit about the clinical data that we do. So about 31% is just for sort of general clinical advice regarding a patient. You know, it could include a multitude of things, really. 26% of that time is for IV access or venipunctures. That takes up a good chunk of our work, really. About 12% are attending patients who are flagged up as high news scores. 7% for chest pains or 12-lead ECG, arrhythmia advice, that sort of thing. 3% verification of expected death. And then sort of in the little figures down the bottom, only about 1% of all our time is attending 222 calls, which sort of feels right, really, so there's not that many 222 calls placed within the hospital. And then we classify the other bit really, 19%, which could include other things, so managing catheters, pain relief, central venous line care, epidural care, those sorts of things fall into that category. And then for the managerial data, about 27% of our calls are for bed management issues, 26% for staffing, 15% just put for general ward assistance. So that might be, I don't know, helping a ward that's particularly busy at the time, helping with the IV antibiotics, sitting with a confused patient, those sorts of things. About 9% of our time is spent dealing with transfers, and they generally tend to be, by transfers I mean sort of off-island transfers. And the remainder 19% dealing with all things, complaints, security, fire alarms, those sorts of things that might happen. Under reliability, so what we sort of discovered really is that people have lots of different ways of assessing their patients, and there's probably no right or wrong way of doing it. You know, we try and promote using the ABCDE format, which is generally what we're teaching everybody to do. What we have tried to do is sort of introduce some sort of standard documentation that the site coordinator team can use, because at the moment really people are generally just writing their assessments in the medical notes of the deteriorating patients, and sort of some of the comments that we had back from staff, particularly in the medical staff, as everyone sort of has a different way of documenting stuff, and what they generally liked was some sort of concise way that gets to the point of what's wrong with the patient. So we sort of tried to introduce some sort of documentation that would sort of support that. So we're trialling that at the moment. Transparency. So like I said, we collect the audit data from the team. This is shared with the clinical leads, and I did an annual report at the end of last year, sort of outlining the audit data to date. You know, we can use that data. You know, there's lots of useful information there in terms of, you know, we can see how often the News 2 scores being escalated, how often the patients are being flagged as sepsis, and how we're sort of dealing with those things. You know, we can use the data to sort of try and justify, if you like, the development of advanced practice, the need for advanced practice roles. And also we collect lots of bed management data. There's a daily spreadsheet that we use, which informs basically the admissions department and the senior managers in the hospital, and it provides an overview of where the beds are in the hospital, staffing levels. We use something called the SNAP tool, which you may or may not be familiar with, which is a tool that the ward staff use to try and identify the acuity of their wards based on their staffing levels as well. So we collect that information, and that gets fed back into the morning safety huddles that is held between all the ward managers and the senior staff in the hospital. And so that meeting, that quite often decisions are made around, is it appropriate to be bringing in all the elective patients that may be booked for that day, where the staffing is needed. And there's an escalation plan in place should the hospital end up on what's known as black alert, which is when we're got more than sort of 95% bed capacity. So again, that feeds into that system. So that's all data that the site coordinators collect, and it's collected once by the night staff at sort of 7 o'clock in the morning, and then again the bed management team updated again at 4 o'clock in the afternoon. But basically it's used as a continuous tool throughout the day, and it provides us a sort of snapshot of what's going on. And ultimately, you know, we'd like to do some work about it. It's sort of it's a spreadsheet filled in on Excel, but we'd like to try and make it maybe a more interactive tool. So we're looking at possible ways of trying to you know, looking at devices where you have a handheld device and just sort of keep it as a live spreadsheet, which everybody could see. So, you know, we're looking at that at the moment. So challenges in the future. So over the last year we have had, like I said, some difficulty recruiting staff with the necessary experience into the role, and at the moment we've only got the equivalent of 3 full-time equivalents in the role. Like I said, we have had a little bit more interest recently, actually, so fingers crossed we might be able to fill a few of the vacancies. So because of that, we're not able to provide a 24/7 cover. We're just providing nights, weekends and bank holidays with occasional days. And as I said earlier, the extra hours during the day are having to be covered by the number ones or the ward managers. We did feel, so we reviewed the job description, and we felt that possibly the title clinical site coordinator, if you look at a lot of the NHS jobs out there, clinical site coordinators refer more to bed management jobs rather than sort of the clinical role that it's been demonstrated to be, really. So we're looking at the job description at the moment and looking at possibly changing the title of the job description to make it sound more clinically based, and looking at the sort of general overview of the description, not necessarily to change a huge amount in it, but I think to try and emphasise the clinical part of the role, maybe to try and make it more attractive to people possibly looking at the job. So at the moment, if you're looking for a sort of a clinical outreach type job, you'd probably type into search engines critical care outreach, those sorts of things. Obviously that would miss the current job title, so we're hoping change of name may help. Like I said, we're working towards ultimately further down the road, we would like an advanced practitioner model, but we're a little ways off achieving that. And I think we'd like to establish ourselves more so with the multidisciplinary team and try and sort of improve the collaborative working with everybody, really.
Okay, so a bit of a background about why we thought that these were necessary. So maternal sepsis, obviously I'm a midwife, so I'm talking about maternal sepsis. Some of it is relevant to all sepsis, but this is in particular about maternity for now. So sepsis is a leading contributing factor to maternal deaths in the UK. The onset of life-threatening sepsis in pregnancy, or the puerperium, which is the postnatal period, so the weeks after you've had a baby, can be insidious, which means it kind of can creep up on you, not very nice at all. Extremely rapid clinical deterioration, particularly with streptococcal infection. And a lot of the women who died were only ill for a very short period of time and were really, really unwell by the time they arrived in hospital. So this graphic is it's from Embrace, which is our Mothers and Babies confidential inquiry department. So they assess, they look at all the mum and baby deaths and make stats and data out of them to help us to improve our care. So this here is the maternal deaths. The darker part are the indirect deaths, so things where somebody might have recently had a baby or be pregnant and die from heart disease or cancer or something that's not necessarily due to the pregnancy. But this one is about bleeding, preeclampsia, women that have died from those sorts of things. Sepsis is in both. So the indirect causes of sepsis might be flu and other things that everybody gets infections from. So we now recommend all women that are pregnant have the flu jab. So that's one of the things that we're trying to do now. But this bit here, so think sepsis. So almost a quarter of the women who died from sepsis, which is severe infection, if anybody doesn't know. So women with sepsis need early diagnosis, rapid antibiotics, and review by senior members of the team, doctors, midwives, anaesthetists, etc. So that inquiry was from the period between 2009 and 2012. So 2 years after that, they looked at it again, and unfortunately, maternal sepsis was still a problem. There was no improvement in indirect deaths, so we really started pushing the flu jab. That was a real major thing we've done since then. And substandard care, as with most incidents, they always find, that often it's the human factors stuff that makes the difference. So if we can improve our care, then they would obviously have better outcomes. So what can we do? So encourage women to take the flu vaccine and our recognition and management of sepsis. Group A strep is the real killer with pregnant women. It used to be called childbed fever. And the risk factors, the risk factors for getting group A strep are working with or having young children, so that's most of our women. The immediate postnatal period, we think sometimes just the very easy hand washing, encouraging our ladies to wash their hands before they use the toilet, so they're not spreading any infection. Maybe when they're just wiping themselves down below, they can, infection can get into the bloodstream very easily if they've got a bit of a wound or from where the placenta's been. So just encouraging people to wash their hands is a really good one, and it's much more common in winter. And the additional factors for our women are things like retained products of conception, things where there's like a foreign body that might become infected within the mother, prolonged rupture of membranes, that's where waters have broken for a long time, so there's this, the risk of infection and ascending infection getting into the mother's bloodstream. And then other things that we do to them. Give me a chance to read those. So there's lots of reasons why our women are at risk for sepsis. And Embrace really stressed the communication and human factors side of reducing risks to mothers. And so another reason why we thought the box and following these pathways is really good, because it takes out those human factors errors that people can make. With a checklist like these, you can, the most junior member of staff can say, well, it says on this checklist that we should do this, and it just gives people a prompt and a bit more courage. And we're not all geniuses and we can't remember everything. So these give you a little bit of a prompt to make sure that you're not missing anything. NICE and the Sepsis Trust both got together in 2016 and came up with this Sepsis 6 pathway, which it's really easy to remember on the front of the box. I like it. Give 3 and take 3. So if someone's really poorly with sepsis, you need to give them oxygen, give them fluid, and give them IV antibiotics. And take 3, which is to take blood cultures to see where the infection is, what the infection is. Bloods for lactate. If someone's really poorly, their lactate will be high because their oxygen levels are low. And measure their urine output. Again, their urine output, if they're not weeing very much, then that's a sign that they're really, really poorly. So the Sepsis 6 is that you want to do these 6 things within an hour, and that's been shown to rapidly improve outcomes. So in midwifery we have a Muse chart. Nick was talking about the Muse chart. Ours is just slightly modified for pregnancy. So any woman that comes in, anyone that's admitted, will have a Muse chart started. And if we get any red scores, it says on the back, what you should be doing to follow that up. So if we're concerned about a woman at all, we think it might be sepsis, then we'll grab one of our checklists, which you've got there. And basically these checklists, they're nice, they're the Sepsis Trust, and they're also prompt. So in maternity, our training, our mandatory training is we use this prompt program, which is practical obstetric multi-professional team program. So lots of very clever people who've done lots and lots of research to inform what we have on our checklist to make sure that we're giving the best care. So basically, once you suspect sepsis, you have a look and see what the problem is, and if on there it says, if you've got any red risk factors, then you do the Sepsis 6. So as soon as you've got any concerns, you grab the box. And within the box, I think that's the next thing, isn't it? Within the box, it's just got everything in it that you need to do those Sepsis 6, and it just stops lots of people running around trying to get the equipment they need. You can all be, just need the staff, and then you can just open the box. It's got the checklists in it, so you can just go through. There's sort of a bag for giving fluid. There's so you can give that to somebody and they can crack on, cannulate the lady to give her the fluids, and then this one is for setting the fluids up. We've also got a copy of our antibiotics, what antibiotics we needed to have straight away, so the doctors again don't have to say what antibiotics should we give her. It's right here. It's just it just takes out all of the worry that you're doing it right. Even the doctors sometimes need a bit of a hand. They've just come from somewhere else where they're doing something really important, and they need to have a quick reference to remind them what they should be doing next. It's got the blood cultures, oxygen mask, catheter just to remind them about the fluid, and then bits and bobs for taking bloods, the lactate. Basically everything you need is in here, including a little sharp spin and some fluid charts and things like that. So we found these, we saw these boxes. It was actually our matron saw them on Twitter, I think it was in Stratford or somewhere they were using them. Stockport were using them. So we got in contact with them there and said, where did you get your boxes from? What's the story with them? And actually it worked out that you could buy them in bulk, and that was a bit more reasonable. So we were like, why not share what we discovered? So we, one of our midwives, sent them what we wanted to be put on it, the States of Guernsey. I think we got 20 boxes, and we spoke to the infection prevention team first before we ordered them all, and they said, it's a great idea. Why not have them across the whole hospital? So I think everywhere except A&E and theatres now has a box, and they possibly have a different checklist. That's the only difference. Other than that, most of it is the same across the hospital. And in maternity, what we did was we've got a theme of the month board on the ward. It's in our kind of handover room, and so in May the theme of the month was sepsis, so we introduced the box to everybody then. Every morning at handover, throughout the day, we've got a safety briefing during our handover. So during that we sort of just told everybody that the new boxes were in use, and every single member of our team has to go through our prompt training annually. So one of our subjects this year has been about the sepsis and the introduction of the boxes. So hopefully everybody knows about them, knows where they are, knows when to use them, and we're just starting to audit them now and see how often they're being used. Actually, what it's done with us has reduced a little bit how many people are having the sepsis 6 pathway. I think previous to the boxes and the new checklists, anybody with a temperature, immediately had the blood, blood cultures immediately sent. A woman might come in, and felt pretty well and just had a bit of a temperature, and immediately then suddenly everyone's running in and scaring the life out of her. And actually, it wasn't necessary. So the new checklists will guide people to how important, when it's important to use them and when it isn't. Because sometimes with pregnancy, sometimes a borderline pyrexia might just be that her breast milk's coming in or something, and she's not septic, she's okay. So the guidelines are useful. So that's just a list of all the contents, different packs and what's in them. And that's our pathway, our checklist to make sure that we don't miss any of the sepsis 6. And that's it.
Hi everybody, so I'm Dawn Watson and I'm the risk management midwife in maternity, so it's my day-to-day role to look at incidents and try and provide feedback to staff. So can I just ask, who in the room actually inputs clinical incidents? Yeah. Who's ever input one and not had any feedback about it? Loads of times. Okay. So we all know the benefits of incident reporting. So we want to identify risks, reduce harm to our patients, be that either actual harm or potential harm, improve patient safety, identify those cases that may need to go to our lawyers, learning from our mistakes, changing staff attitudes and knowledge, and being able to measure the impacts in hopefully having a beneficial change in care and facilitating the standards of healthcare governance. So the background. So as many will know, we had a quite complex review of maternity services back in 2014, and throughout that a number of staff, nearly all of the maternity staff, were interviewed, and one of the things that came back was that staff said they didn't feel they got feedback when they escalated their concerns, whether that was through the incident system or through direct lines to management. So one of the recommendations from the NMC was that we had to review and embed systems to support escalation of concerns relating to practice and safety. But I'm sure you all know that we're not alone in this. So if you go back to France's report, staff are entitled, I quite like that, to receive feedback in relation to any report they make, including information about any action taken or reasons for not acting. And when I did some reading around, actually a lot of the literature says that as little as 20 to 50% of staff get feedback from incident reports. So how did we do it back before 2014. So a lot of it was based around very brief notices. We'd have a notice that went up once a month with 5 key things that we were meant to take from that month's incident reports. And it would often be just a very brief topic like that, sort of remember to document this, sort of be polite when answering the phone, complete your training. So it was very, very brief, non-specific, sort of wasn't actually related to individual cases. So I don't think, sort of had any real benefit. So as we were moving on to our improving things, we tried lots and lots of different things. We introduced weekly incident meetings. We had cascade boxes. We introduced a governance and risk board. And we also produced a monthly report. But what we found was that actually the staff were becoming disengaged. They weren't coming to the meetings. There was huge amounts of effort, sort of to put all these meetings together. We had no way of knowing whether it was having any impact, and actually from what we could see it wasn't, because we weren't seeing the improvements that we actually wanted to achieve. So we looked recently, as Emma sort of showed the Embrace thing, sort of that actually a lot of sort of different companies and sort of like we've got the CQC, we've got Embrace, you've got Headway here, are all turning to this more infographic way of giving feedback, sort of quite punchy, really grabs your attention and colourful. So we looked at changing our tack. So we've got a newsletter which Elaine will pass around for you to have a look. So that contains a little bit more of the boring stuff, the trends and the analysis, but it also has some education and training and a few quizzes in there just for a bit of fun, sort of, and also helps us to look at whether the changes and the education that we're putting in is actually being embedded and staff are actually learning from that. And then we also introduced what we call our watch out for notice, which was picked up when we've been doing a swap of staff back, like sort of going over to Portsmouth to visit their maternity services over there, and we actually picked up this from them. So it's quite simple. They're quite easy to produce, sort of in relation to an incident, so we can, sort of once it's been reviewed, we can get these out quite quickly. It has basically looks at 9 different points. So 3 points around what was it that actually happened, what were the facts, and what can we do to protect our patients. So obviously the facts, sort of that's, sort of what learning can we get out of it, and protecting our patients, we're looking at, sort of your safety factors. So this is just one that we had related to neonatal jaundice and neonatal weight loss, and sort of around PPH and calling 222. So a lot of them are either specific incident related, sort of, so there'll be one incident that triggers it and we'll put one out, or some have been in relation to trends that we've seen. Like this specific one was around, we had quite a trend in and an increase in PPH, so postpartum hemorrhage, and it was interesting, like a change that we'd actually implemented to try and improve it, we'd found had actually inhibited people from calling, because we'd said call the emergency situation when the bleeding hits 1500 mils. What we didn't realise was that people were waiting for it to hit 1500 mils before they called it. So then, sort of we had to backtrack and put in a little bit of work around that. It's a brilliant revalidation tool. So because you're already looking at, sort of how are you preserving the safety of your patient. So the staff can actually take their a copy of the watch out for notice, put it in their portfolio, and write their reflection around that. So we're already pointing them to the bits of the code that you need to. So we thought, sort of that was kind of proving quite interesting, and people were really enjoying and sort of finding that helpful. So we thought we'd try and improve that and continue the vision into giving feedback from other things as well. So we've recently thought about how do we give feedback from our monthly governance meeting. So we've turned to using an infographic representation of that. So again, the new guidelines that are coming out, our compliance, great things like, we got 100% of women who chose to have a vaginal birth after caesarean section last month actually achieved it, which is really brilliant. Compliments and complaints as well. And then we thought, well, we've done it for us, why don't we try doing it for our women and families as well? So we went out six weeks ago, maybe?
Yeah, and it was a service user that put it on their local bailiwick Facebook page that from one of the places in London, so we just unashamedly nicked the idea. And that's how we share our infographics with the users.
So we actually shared this with our service users through the National Childbirth Trust Facebook page, and it had huge amounts of comments and feedback, and it all seems to have been received really positively. So closing the loop, so ensuring that staff are getting the feedback is and that feedback is provided in an acceptable method. And I think from the reading that I've done, and obviously the things that we've tried to implement, that there isn't a one thing fits all approach. And I think we've got to get to the point where we're providing feedback in multiple different ways. So we've now got our newsletter, we use our infographics. Myself, and the management team do that personally. We have case review meetings with interesting cases, both good and bad, and the watch out for notices as well. And then, we need to monitor that, obviously, to make sure that that is then having the impact and the desirable effect that we want. And we, and hopefully, then that will improve our working environment and our staff morale. And I thought that might be I just thought I'd put that on because it might get a thing. We do hope to see an increase in incident reporting, not a decrease, because from all the literature it says, if your staff feel safe and valued and they get good communication, then they will feel safe to escalate their concerns, and they will feel safe, to put in incident forms and near misses, and so we can all learn and develop that safe non-blame culture. So feedback now, as I've just said, is provided in multiple ways. Infographics that are succinct and to the point, the ability to get the key message out quickly and efficiently, easy to read and user friendly. None of us want to spend our 30-minute break reading millions of pages a month. Provides details of the event and recommendations, and it's revalidation friendly. And our next step is to continue to monitor to ensure effectiveness and progress. Thank you.